Hi, my name is Heidi Hazy, and this is my presentation on Hashimoto thyroiditis. A 38-year-old attorney reported for her yearly physical examination complaining of tiredness, difficulty concentrating on her work, and a noticeable decline in her memory over the past several months. She attributed many of these symptoms to the severe stress generated by her legal caseload. Further questioning by her physician revealed that the frequency of her bowel movements had decreased from once daily 6 months ago to once every 2 or 3 days. She was having difficulty avoiding gaining weight, and despite warm weather, she felt chilled without a light sweater. Her only medication was an oral contraceptive. Physical examination revealed a well-proportioned woman, 65 inches tall, weighing 125 pounds. Physical examination also revealed sparse eyebrows, particularly at the lateral margins, and a diffuse, moderately enlarged thyroid gland with a prominent pyramidal lobe above the isthmus. I chose this topic because when I was in high school, I had a moment in time where I experienced the signs and symptoms of hypothyroidism, extreme fatigue, weight gain, even when I was an active teenager. My TSH level was low at 0.03, so my primary sent me to a pediatric endocrinologist who ran more blood work testing for thyroid dysfunction. All of those labs came back negative. She diagnosed me with a viral thyroiditis because I had recently had a cold, and she thought that virus could have caused the thyroid to malfunction. What she did tell me is to be careful and keep an eye on my thyroid levels because that viral thyroiditis could lead to Hashimoto's disease, and I would then need treatment. So my primary physician checks all of the thyroid functioning tests with my yearly blood work, and I'm aware of the signs and symptoms that might trigger me to go get looked at sooner if need be. Her laboratory findings are as follows. Hashimoto thyroiditis is an autoimmune disorder where the immune system attacks the thyroid. While the exact cause is unknown, there are many factors that are involved, like genetics, hormones, exposure to certain medications and radiation, and viruses. The symptoms include excessive fatigue, unexplained weight gain, being cold, trouble focusing, having a foggy memory, and skin discoloration on the neck called a thyroid shadow. The thyroid shadow is a common symptom of thyroid dysfunction, and we as healthcare providers should be monitoring our patients for them. What I found interesting about this article is that it stated that the thyroid is an organ that has a high level of selenium. Selenoproteins help to protect our thyroids from exposure to reactive oxygen radicals that are synthesized in the course of hormonal biosynthesis. When a patient has hypothyroidism, there are decreased serum levels of selenium. So the authors performed a study to see whether the implementation of selenium in patients with hypothyroidism, more specifically in Hashimoto's thyroiditis because the levels tend to be lower in that disease, would not only help the thyroid shadow but to help protect the thyroid from oxygen radicals. The study was inconclusive, and there's a lot of testing that needs to be performed to see if there is any actual effect. However, I just thought that this was extremely interesting. This article is about certain neoplastic drugs and how they are linked to causing thyroid dysfunction. Some of these common drugs include an iodine-based therapy. Incidence rates range from 9 to 41%, and hypothyroidism may be prevented with the use of a Lugol solution or saturated potassium iodine. TSH should be measured at baseline and semi-annually. Interferon, patients have a 2% to 10% risk for hypothyroidism related to autoimmune thyroiditis. Onset varies from 1 to 23 months, the median being at 4 months, and is permanent in 60% of patients. TSH and antithyroid peroxidase antibodies should be measured at baseline. TSH is measured semi-annually if the anti-TPO test result is negative and every 2 months if it is positive. Interleukin-2, 10 to 50% of patients develop thyroid disease associated with autoimmune thyroiditis, leading to hypothyroidism and thyrotoxicosis. Patients should have TSH screening before therapy and every 2 to 3 months during therapy. Thalidomide. 10 to 20% of patients will develop either hypothyroidism or thyrotoxicosis within 1 to 6 months after treatment is initiated. TSH levels should be measured at baseline and every 2 to 3 months. Now, I know that we have to treat our patients with these medications if they're diagnosed with cancer or whatever other diseases that we would use these medications to treat. However, this is definitely something that we need to know as future DNPs. We need to watch for this in our patients that have received any of these medications, and we need to educate our patients on the signs and symptoms and what to watch for, such as extreme fatigue and unexplained weight gain. While extreme fatigue can be caused from their cancer treatments, we need to make sure that we are able to rule out any thyroid dysfunction. This article discusses how normal thyroid function can be disrupted in the postpartum woman caused from the immune rebound after the immune suppression that is essential to pregnancy. This is called postpartum thyroiditis. They typically have brief periods of signs and symptoms of both hypo and hyperthyroidism, which are missed because they're typically attributed to the normal ebbs and flows of recently having a baby. This article is interesting because it discusses that women who have a known thyroid problem before becoming pregnant should have regular blood work to ensure that their thyroid is functioning properly, but also that women who suffer from postpartum thyroiditis may represent the uncovering of thyroid autoimmunity that was silent before pregnancy. This is important for us healthcare providers to screen for thyroid issues before, monitor for postpartum thyroiditis after the baby is born, and monitor the mother for any signs and symptoms of thyroid dysfunction, as it can be a precursor to an underlying autoimmune thyroid issue that was not known before.